This video is a guide to the process of intubation of a positive or suspected COVID-19 patient from the ward who will have surgery in ADHB operating rooms. It follows the checklists available in the auxiliary documents and should be used in conjunction with the perioperative COVID-19 guideline. Staff and patient safety are our priorities. This process is written in a way to minimise exposure to staff and to reduce contamination. The aim is to keep the time in which there is potential for aerosolization to a minimum. All drugs and equipment that may be required during intubation and the 10-minute stand-down period should be available in the operating room. The red bell should not be pressed during this time. Therefore, a robust plan for patient management should be established. Closed-loop communication and speaking up is encouraged. The intubation brief checklist is available in the auxiliary documents. This brief is led by the anaesthetist and involves the technician and third nurse while the patient is being collected from the ward.
Okay guys, so while we're waiting for the patient to come up to theatre, I thought we could do the intubation briefing. I just want to make a point that while we're doing the intubation, I really want us not to rush and we'll do things slowly and carefully so that we're looking after ourselves. If we could really focus on using closed loop communication as well, just so that everyone's on the same page of where we're up to.
Sure. Thanks, Liz.
Okay. So the first thing we'll do is just optimise our intubation conditions when the patient gets in. So we'll make sure that the patient's positioned appropriately and we have a good period of pre-oxygenation. And then we'll do a rapid sequence induction with no cricwood.
Okay.
The equipment that we'll need is a video laryngoscope, a bougie and a size 8 tube.
They're all here.
Great. And Kay, I'll actually ask you to give the drugs and I'll tell you the dosage in mils.
Do you want those on my tray?
Yeah, you could put them there. It's recommended that we don't use positive pressure ventilation until the cuff is inflated and the circuit's connected.
All right.
So even if the sats dip a little bit, we'll just wait until the circuit's all connected and the cuff is up to keep ourselves safe. We'll also make sure that the patient's fully paralysed before we start the intubation so that the patient doesn't cough on us. After I've used the bougie, I'm going to really carefully take it out and put it straight into the rubbish bin. And then after intubation, if you could inflate the cuff, Kay, I will connect the anaesthetic circuit, and then if you could bag the patient and then confirm end tidal CO2.
Okay.
I'll then ask you to start the ventilator. So our rescue technique will be an eye gel. If we use the eye gel, we'll need to cover the patient's head with a plastic sheet.
We've got an eye gel 4 and a plastic sheet.
Okay, great. If we get to that stage, we'll just make sure we get to a point of safety and then we'll talk about what our ongoing airway plan will be from there. In terms of patient-specific considerations, apart from this patient being coronavirus positive, there's nothing specific about this patient that I'm concerned about at this point. But if you've got any concerns at all, please speak up. Everybody should speak up if they notice something, especially if we've got a PPE breach, and then we can address anything that we're worried about. Have either of you got any questions?
No, I'm happy.
No, all's good.
Great. We'll get going then.
The intubation process checklist is available in the auxiliary documents. This is read by the nurse, who remains 2 meters from the patient and ideally parallel to or behind the patient's head. This scenario begins once the patient is on the operating table and only the airway team remain in the room.
So Simon, we're just going to get ready to get you off to sleep now. So you'll hear us talking to each other and we're just going to say our instructions out loud. Just a reminder that when you wake up you will have a plastic sheet over your face. Don't worry, that's quite normal. Okay? Kay and Selena, are you ready to get going?
Yeah?
Yes.
Alright, we might start then.
Okay, so I'm just going to read some instructions aloud and then pause for you to complete the action. Once you've completed the action, could you please acknowledge that you have? Rubbish bin on the left within easy reach of anaesthetist.
Thank you.
Tray on right side of patient pillow.
Completed.
Please listen to this full statement before starting. Tick to turn off oxygen and disconnect from machine. Anaesthetist cuts surgical and Hudson mask ties, removes both, and disposes of both immediately in the bin. Tech hands the face mask, which is immediately applied using two-handed technique.
Okay, thank you.
So I'm going to turn that to light now.
Thank you.
That's
And I'll
confirmed.
cut the ties, but I won't take the masks off until you're ready. Okay, so ready with the mask?
Ready.
Okay, we've completed that.
Turn on oxygen flow and commence pre-oxygenation.
Oxygen's on 6 litres.
Final airway assessment and final airway plan verbalised.
Simon, can you just open your mouth for me? That's great. Okay guys, so I think we'll stick with the original plan, which is a rapid sequence induction with no cricoid and a size 8 tube. You've got the glide scope go there.
Correct.
Perfect.
Reminders during pre-oxygenation. No positive pressure ventilation. If suction required, this is handed in by tech. If yanker used, discard directly into bin. When ready, tech gives induction drugs.
Thank you.
Alright, so our end tidal oxygen is 0.9, so I think we're ready to give the drugs now. Are you happy?
Yes, I'm happy.
Okay, so we'll give fentanyl first. So
Fentanyl?
3 mils of fentanyl.
3 mils given.
Great, and then propofol.
Propofol.
So 10 mils of propofol. Just going to sleep now, Simon.
10 mils given.
Thank you, and then sucks. So I want you to give 2 mils of that, which is the whole syringe.
Succinylcholine. That's given.
All drugs are given.
Reminders while waiting for paralysis. When disconnected, place face mask in tray with circuit facing away from staff. Anaesthetist carefully discards bougie and connects circuit. Anaesthetist does not touch bag or machine. When ready, perform intubation with bougie.
So we'll just wait for these fasciculations to finish. Have the suction, please, Kate. Thank you. Got a good view here. The bougie's through the cords.
Reading the tube on now. Got the bougie.
Thank you. It's passing the tube now. So the tube is through the cords.
Tech inflates cuff.
Cuff inflated.
Thank you.
Anaesthetist to place laryngoscope in additional tray.
Thank you. Okay, if you just step back, I'm going to carefully take the bougie out.
Tech sets APL to 10 and bags patient. Tech confirms CO2 trace and starts ventilator and volatile as instructed.
So confirmed CO2.
Great, so you can turn the ventilator on. And could you put the SIBO on 2% and the oxygen on 2 litres, please?
That's confirmed.
Thank you.
Anaesthetist to secure ET tube and tape eyes. Consider temp probe and NG tube.
Thank you. right, and we don't need a temperature probe or a nasogastric tube for this patient.
If suction was used, tech turns it off, disconnects tubing at the canister, and it is placed in the rubbish. Reminder, a second suction tubing will need to be brought into the OR during the case. The team removes outer gloves and performs hand hygiene over their surgical gloves.
Confirmed.
Right, that's complete.
The 10-minute stand down begins now. I will start the timer.
Thank you.